We'll get started because I don't want to go over. It's an honor to be asked to introduce a resident anytime for Grand Rounds, and it's especially an honor to do it for Eugenia. I've known her since she was a senior medical student at U of L, and prior to her graduating from medical school here in 2013. She was a magna cum laude graduate in economics from Bellarmine, and then while in undergraduate school, she worked for a brief period of time in the accounts division at Humana, where she was most likely denying hardworking physicians their rightful reimbursement. Humana's loss, though, was Dr. O'Malley's gain, as she worked as a research assistant for him in his lab prior to beginning medical school, and she's done lots of other things, and I'm not going to stand up here and just regurgitate her CV. But the most important thing that she did for us was deciding to stay at U of L for her residency in psychiatry. And since she's been here, she has distinguished herself as one of the brightest, most hardworking residents that I've personally had the pleasure to work with in anywhere doing anything, including surgery. And I love her to death, and I give you Eugenia Brikker. Thank you.
Thanks, Dr. Campbell. Let me get my PowerPoint up. All right, so I will be talking about catatonia today. And our objectives are to recognize that catatonia is a syndrome of related disorders with variable presentations, to be able to diagnose and treat catatonia in a timely fashion, and to be able to differentiate catatonia from similar syndromes. So why did I choose this topic? I first got interested in it when we had a patient in July or August of last year, and I will actually present his case because he unfortunately had an unfavorable outcome. And I didn't pick up on what was going on with him, so I started doing a lot of reading about what happened. So I found out that catatonia has a highly variable presentation, and there's a lot of overlap in symptoms between different variations and similar syndromes. And the most important thing about why I picked this topic is because successful treatment is really time sensitive. The delay in diagnosis and initial treatment really results in a high mortality rate. There was a paper published in earlier this year where the author was encouraging psychiatry and the ICU to collaborate earlier in patients diagnosed with a variant of catatonia, malignant catatonia. And they noted that there's a lag time of at least 15 days between the first catatonic symptom to treatment. There was another study that noted there was an actual lag time of 60 days. And given that the treatment is time sensitive, that's a really long time to wait. So let's start out by, this is just our outline and the things that we'll cover today. So I'd like to start out by going over this case. This patient was a 74-year-old white male. He had a history of unspecified anxiety and major depression with psychotic features, and he was referred for admission by his outpatient provider. He presented with a 2 to 3 week history of worsening anxiety, constant worry about money, inability to get things done at home because he was feeling confused, and poor sleep. His past psychiatric history was significant for one previous admission in May of 2015 when I took care of him as a second-year resident. At that time, he presented with a lot of worrying behaviors, a lot of pacing behaviors, and these were subsequent to his wife dying. His past medical history was really unremarkable. He had a B12 deficiency, BPH, but nothing really significant. His social history, he was married for 47 years and was widowed in April of 2014. He now lived alone. He worked at Heaven Hill Distilleries and retired from there. He did not have any combat history, no history of drug or alcohol problems, and no history of legal problems. His home medications at the time of admission were Remeron 15, Buspar twice a day, melatonin, Klonopin, half a milligram in the morning and a quarter of a milligram at bedtime. It was recently tapered, and that was thought to have worsened his symptoms. On admission, his mental status exam was significant for A lot of psychomotor agitation. He was noted to be fidgety, unable to sit still, rocking back and forth, pulling at his t-shirt, picking at his skin. He was alert and oriented times 4 and didn't have any evidence of psychosis. His physical exam, he had a steady gait. There was no noticeable tremor. All of his labs were normal other than a mildly elevated ALT at 63. His initial hospital course was marked by him asking a lot of repetitive questions. He was noted to have constant psychomotor agitation. He was pacing, restless, squeezing his hands, making and unmaking his bed, marching in place, pacing in circles, stepping forwards and backwards. There was an instance that was the documentation from this patient is actually rather excellent, so I had a lot of stuff to go off of. And there's an instance where he's described as having a difficult time taking his medicine. He's noted to be starting and stopping to take his medicine, picking up the cup and putting it down, but unable to actually take the medicine. He had variable tachycardia throughout his initial hospital course. He eventually developed paranoia and delusions related to his finances and his bowel habits. He was very focused on whether or not he was constipated, and this was very repetitive, every day, same conversation. Initially, his Remeron was increased to 30 milligrams, and his Klonopin was increased back to 0.5 milligrams twice a day without any noted improvement. Due to the development of the paranoia and delusions, he was started on Seroquel, which was titrated up to 100 milligrams twice a day. On hospital day 10, he had an episode of diaphoresis and tachycardia without any rigidity or hyperreflexia. This was accompanied by a CK elevation to 1,209 and a slight bump in his ALT and AST from baseline. At that time, all of his medications were stopped, and he was started, I believe a day after, on Valium 10 milligrams 3 times a day. And then eventually, 3 days later, he was started on Zyprexa at a low dose, which was titrated up to a final dose of 10 milligrams twice a day, along with the Valium 10 milligrams 4 times a day. He continued to show no improvement. In fact, his symptoms progressively got worse. He had psychomotor agitation, which was worse. The behaviors described above became worse and more repetitive. He started to believe he was going to die. His mental status worsened, and he began to have a poor PO intake. He was transferred to U of L on hospital day 17 for a full neurologic workup. So on admission here, all of his psychiatric medicines were stopped. So the Valium and the Zyprexa were discontinued. He was evaluated by neurology and noted to have chorea-4 movements, rigidity, negative myoclonus, and altered mental status. The neurology notes say that they believe that it was medication-induced. They briefly mention in their differential that this could be NMS or maybe serotonin syndrome, but overall they felt like it was medication-induced and psych needed to see him. This gentleman had the most extensive medical workup out of anybody I've ever seen. He had so many lab tests done, I had to look up to see what they were. So he got tested for every paraneoplastic syndrome you could possibly think of, just everything. Complete autoimmune workup, and everything came back negative. His initial labs were significant for just a mildly elevated CK at 354 and an ALT of 76. His UA was nitrite positive, so he was treated for a UTI. He was seen by psychiatry and felt to have an agitated depression with psychosis, and the recommendation for treatment was ECT. While we were attempting to get consent for ECT and he was getting cleared, he received 2 doses of IM Haldol for agitation and subsequently became febrile with a core body temperature of 103 degrees Fahrenheit, worsening tachycardia, worsening mental status, and rigidity. His labs eventually became significant for a leukocytosis with a left shift. He had a white count of 19.7 without really an identifiable cause for that white count. CK bumped to 947. His sodium was high, and he had other various electrolyte abnormalities throughout his hospital course. He had autonomic instability. He was tachycardic persistently. Blood pressure was elevated. He had an episode where his systolic blood pressure spiked up to the 200s, and there was even concern for a possible stroke, so he got a CT, which was negative. He had a normal EEG. He eventually was transferred to the ICU because he was having episodes of increasing hypoxia, having a really difficult time clearing his secretions. He was tachycardic, febrile, and increasingly more confused. They did check a D-dimer, which was elevated. His lower extremity ultrasound was negative, but they didn't get a CTPE protocol because he was so agitated. He did have one treatment of ECT, but later on in that day, he had to get intubated due to hypoxia. It was believed that he had aspiration pneumonia, but he did have negative chest x-rays, so there wasn't anything there. The day after he got intubated, he was made DNR by his family. He was extubated and transferred back to the original facility on the palliative service and then expired several weeks after the transfer. So I'm sure at this point you're probably asking yourself, why am I presenting this case in a grand rounds on Catonia? So I hope that I cover that as we go through this case. I'd like to start out by just looking at a little bit of a historical perspective on Catonia. In 1583, this was one of the very first descriptions of catatonic behavior made by Philip Burrough. He was a British physician, and he described a patient that was in stupor as taking both of mind and body, both sense and moving being lost, the sick remaining in the same figure of body wherein he was taken, whether he sit or lie or stand, or whether his eyes be open or shut. Then in 1663, Robert Bayfield described a patient in catalepsy. So he described somebody that was a sudden surprisal of all the senses, the motion, and the mind, with which those that are seized upon and invaded remain and abide stiff in the very same state and posture in which they were taken and surprised, with their eyes open and immovable. Another I saw like a dead man, lying along with neither seeing, hearing, nor feeling when he was pinched. But he breathed freely, and whatsoever was put into his mouth he presently swallowed. If he was taken out of his bed, he did stand alone, but being thrust would fall down. And which way soever his arm, hand, or leg was set, there it stood fixed and firm. You would have taken him for a ghost or some rare statue. Then in 1850, Henry Monroe described cataleptoid insanity as a patient that stands in apparently profound stupor. Their eyes are glued down or else staring open in a fixed manner, so immovable that you do not observe the least twinkle of the eyelid. The skin is cold and clammy. You speak to them, they will not answer. You offer them food, they will not eat. They indeed are most unwilling to move from the spot with which they have taken up. You would say of them at first sight that they are in the perfectly apathetic and probably unconscious state until you try to cross their will, and then you often find a most resolute resistance. The state of the intellect in these cases is often hard to arrive at, for the mind is a prisoner. All the ordinary avenues of expression by which the caged spirit may take flight are sealed up by an influence of a numbing character, which in many points of view seems to resemble simple drowsiness. Sometimes when you lay hold suddenly of such a patient, you may shake him out of the stupor, and you find that his mind is by no means lost. He has a clear perception of all that has been going on even during the trance. Then in 1874, a German psychiatrist, Karl Ludwig Kahlbaum, he really formally names catatonia. He describes it as a brain disease with a cyclic alternating course in which the mental symptoms are consecutively melancholia, mania, stupor, confusion, and eventually dementia. He did say that one of these symptoms may be absent from the symptom complex, and in addition to the mental symptoms, locomotor neural processes with the general character of convulsions occur as typical symptoms. Then in 1896, Emil Kraepelin really incorporated the concept of catatonia and schizophrenia and provided the origins for catatonic schizophrenia. So let's jump 100 years, and how do we view catatonia today? We view it as a syndrome. It is viewed as a motor disturbance in which the patient is unable to move normally despite full physical capacity. There's a lot of debate in the literature whether or not catatonia should be a discrete diagnosis, but most authors believe that it is secondary to either a psychiatric, neurologic, or medical illness. As you can see, most of the descriptions of catatonia throughout history have been of the retarded form of catatonia, so the hypoactive catatonia. There are other forms of catatonia. There's excited catatonia, which is hyperactive, and malignant catatonia, which is essentially either hypo or hyperactive catatonia combined with fever and autonomic instability. And we'll talk about those more in specific as I go through the presentation. Just a few words about epidemiology. The true prevalence or incidence of catatonia is not known. All of the studies are population specific. So we're going to look at one slide where I talk about psychiatric inpatients. So the statistics will apply to that population. And then on the next slide, I'll talk about the prevalence of catatonia in a medical setting. So the prevalence is thought to be somewhere around 10%, with a range of 5 to 20% among psychiatric inpatients. There was a study in 2009 that looked at 148 patients with catatonia, and 46% of those patients were actually diagnosed with an affective disorder, so either bipolar or major depressive disorder. Only 26% of the patients had a psychotic disorder. There was 20% of the patients that had a general medical condition, and then 8% with another psychiatric disorder. It's increasingly becoming recognized that catatonia frequently occurs in patients with autism spectrum disorder, so just something to keep in mind when you're evaluating that patient population. There are many general medical conditions that cause catatonia. In fact, there's more than 100, and these include infections such as HIV or AIDS, CNS infections, metabolic disturbances can cause catatonia, neurologic disorders, or rheumatologic disorders. Lupus is particularly common to cause instances of catatonia. Oldham and Ho-Chang reported in 2015 that 70% of the catatonia in the medical setting is actually due to neurologic disease. Of those, 30% were due to structural CNS disease, 25% due to encephalitis, or other infections, and then 10% is due to seizure disorder. There is a high recurrence rate of catatonia. There was a study that found that 38% of patients with bipolar disorder and catatonia had previous history of catatonia. So in the acute medical setting, the prevalence is somewhere around 1.6 to 6.3%. There was a study done by a consult psychiatry service that found that there's a 12 to 36% incidence rate of catatonia in delirious patients, and the wide range is based on symptom cutoff. Grover et al. Studied 205 patients that met criteria for delirium and found that catatonic symptoms were present in more than 5% of that sample. And they were marked by excitement, immobility or stupor, mutism, negativism, combativeness, staring, and withdrawal were all equal, and then impulsivity. Perseveration is something that's common in both delirium and catatonia, and they found that it actually occurs in more than 80% of cases of delirium, and in their population group, they didn't find it as prevalent in catatonia. So let's look at the diagnostic criteria and clinical features of catatonia, and I'm actually going to spend quite a bit of time going over this because I think this is the meat and most important part of the presentation and kind of where I was having the most trouble. So according to the DSM-5, the clinical picture is dominated by 3 or more of the following symptoms. There's been some debate on how many symptoms to include, and in the literature, they advocate for making the diagnosis if there's anywhere between 2 to 4 clinical symptoms present for 2 or more hours on 2 or more occasions. If you look at 4 symptoms, it gives you a 100% diagnosis, like it includes everybody, but it excludes a whole bunch of people, so the DSM went with 3. The frequency of the most common clinical signs, so immobility and mutism are the most common, and that obviously leads you to believe that retarded catatonia is the most common form of catatonia, and in fact it is. The other common symptoms are withdrawal and refusal to eat, staring, negativism, posturing, rigidity, waxy flexibility or catalepsy, stereotypies, and followed by echo phenomena. I'd like to introduce the Bush-Francis Catatonia rating scale to you. This is a rating scale that is a 23-item scale, and it has these screening items on the left and then a full scale items on the right. Based on the Bush-Francis Catatonia rating scale, you make the diagnosis of catatonia based on the presence of 2 screening items. It gives you a set way to define each one of the symptoms and to rate them. It's currently mostly used in research, but I would like to argue that it should be used more in the clinical setting as well, because our patient, in fact, did not meet diagnostic criteria under the DSM-5, but he did under the Bush-Francis Catatonia rating scale, and I think that his treatment could have been better tailored had we been more aware of this. So let's go through each of the symptoms individually. We'll start out with mutism. So just like it sounds, it's verbal unresponsiveness. It does not have to be associated with immobility. It may appear to be elective in nature. There's a couple forms of mutism. So a patient that's speaking with progressively less volume until his speech is inaudible is a form of mutism. And then some other forms are things like using a foreign accent that isn't common or typical for the patient, speaking like a robot or a child learning to read, speaking without using word contractions. Moving on to immobility, this is extreme hypoactivity and minimal responsiveness to external stimuli. Stupor is decreased responsiveness or complete unresponsiveness, unawareness of surroundings, and in severe cases, the patient may not even withdraw from painful stimuli. Excitement is defined as extreme hyperactivity. In literature, it's really described as somebody that's frenzied or frantic, constant motor unrest, and this will be purposeless in nature. As we go through these symptoms, the things I highlighted in red are things that apply to our patient. So I just like to keep his story in mind as we go through these. Excitement is not associated with akathisia or goal-directed agitation. It may include things like sudden outbursts of talking, singing, running down the hallway, dancing, or tearing off clothes. Catatonic posturing or catalepsy is spontaneous maintenance of a posture for long periods of time. This can be in the face by facial postures or grimacing, for example, like an exaggerated lip pucker. A psychological pillow where a patient will be laying in bed with their head elevated above the bed as if they're laying on a pillow, but there won't be a pillow. I've actually seen this in a patient. Lying in a jackknife position, sitting with upper or lower portions of the body twisted at right angles, holding arms above the head or raised in a prayer-like manner, or holding fingers and hands in odd positions. Echo phenomena, so there's 2 of these. Echolalia, which is the repetition of statements made by the examiner, and then speech prompt catatonia is where the patient doesn't really have any spontaneous speech. They may repeat questions, and then they answer things with "I don't know" or contradictory yeses or nos. So if you ask them a question in 2 separate ways, they'll answer yes to one and no to the other. And then echopraxia is just the patient spontaneously copying the examiner's movements. Stereotypy is repetitive, purposeless motor behavior. So our patient had a lot of these. It can take the form of rituals or compulsions, sometimes self-mutilation. Patients can have finger play, repeatedly touching, patting, or rubbing themselves, making clicking sounds before or after speaking, opening eyes wide, then squeezing them shut, grimacing, teeth or tongue clicking, tongue chewing, sniffing, pouting, rocking, shoulder shrugging, or marching in place. And then verbigeration is a type of stereotypy where there's a repetition of phrases and sentences in an automatic fashion, like a scratched record. Mannerisms are odd but purposeful movements, such as holding hands as if they were handguns, saluting passerbys, hopping, walking on tiptoes, skipping. They can occur with stereotypes or can be incorporated into goal-directed activity, but done in an exaggerated manner. So staring, Pretty self-explanatory, just a fixed gaze, no scanning of the environment, grimacing, maintenance of odd facial expressions, rigidity, so maintenance of a rigid posture. This does not include cogwheeling, so if a patient has cogwheeling, that is not rigidity. Withdrawal, so refusal to eat, drink, make eye contact, and perseverations, which are repeated returns to the same topic. Negativism is the resistance to the examiner's manipulations with strength equal to that applied, or somebody that does the exact opposite of an instruction. There's also social negativism, so a patient will sleep under their bed, or they will turn away when they're addressed. They refuse to open their eyes, or closing the mouth when offered food or liquid. Waxy flexibility is kind of the thing I always talk about to the med students, where I tell them that'll be on your test. So to define it, it offers initial resistance to an induced movement, but gradually allows to be postured. So it's somebody that, it's like bending a candle. Automatic obedience, so the patient allows the examiner's light touch to move their limb into a new position, despite instructions to the contrary. This may be maintained despite instructions not to. It is recommended to test bilaterally because it can indicate a neurologic disorder if it's only unilateral. And then ambitendency is a patient will appear stuck in an indecisive, hesitant movement. So the example that I always give is that if you offer your hand to shake to a patient and then you tell them, do not shake my hand. And so the patient will kind of be stuck in this moment of, do I shake your hand or do I not shake your hand? So that rounds out the signs and symptoms of catatonia. Briefly talking about pathogenesis, the true pathogenesis of catatonia is not actually known, so there's a lot of hypotheses, but I'm not going to spend a whole bunch of time talking about this. So the current proposed mechanism basically has to do with GABA activity. So it's believed that there's a dysregulation in the cortex, which involves GABA A, and then subsequent dopamine dysregulation in the thalamocortical loops and subcortex. It is believed that a top-down dysfunction of dopamine, so going from GABA to dopamine, leads to catatonia and malignant catatonia, and then that a bottom-up dysregulation, so starting with dopamine and going back up to GABA A, is what happens in NMS. So keep this in mind when we talk about NMS later on in the presentation. So how do we assess a patient with catatonia? This is a large list of things to consider in your differential. I'm not going to go through them because I don't have a whole bunch of time to go through them. I will talk about NMS in a great deal of detail towards the end of my presentation. I do want to say a brief word about toxic serotonin syndrome. As you all know, this is when somebody is exposed to SSRIs or MAOIs. The things that differentiate it from NMS or malignant catatonia are hyperreflexia, myoclonus, ataxia, and then GI symptoms. So those are just things to consider. So the diagnostic recommendations are pretty generic for what we do with most of our patients. We get labs. Consider an EEG. Most of the literature does actually recommend getting an EEG. It will be normal in a catatonic patient, and then in a patient that has malignant catatonia or NMS, they may have generalized slowing, but not always. The only lab that I would like to highlight is a serum iron, and I will talk about its significance in just a couple of slides. But that is the one lab that we actually did not check on the patient that I presented earlier. And that would be important data for us to have. And then most literature does recommend getting an MRI to rule out any kind of neurologic conditions. If a patient looks like they might have encephalitis or meningitis, we would obviously get an LP. And then most of the literature does recommend, even if a patient has a known psychiatric condition, that we should be still getting a rather complete workup just to rule out any medical or neurologic causes or toxic causes, just because the cause can oftentimes be due to multiple conditions. And then the Ativan challenge is an important part of our diagnostic assessment. So the Ativan challenge is basically giving 1 to 2 milligrams of IV Ativan. You can use IM or PO Ativan, but it's recommended to give IV or IM for full absorption. And you should notice a partial or full relief of symptoms in 5 to 10 minutes after IV administration. If there's no change, it is recommended to give a second dose after 5 to 10 minutes, or after the initial 5 to 10 minutes, and then re-examine. A negative response does not necessarily rule out catatonia because it will be negative in about 20% of patients. Alternatively, you can use oxazepam or Ambien, but it is recommended to use Ativan as a first line. So let's look at the subtypes of catatonia and their treatment. I'm going to spend a little bit of time going over general considerations for treatment before I talk about specific things. So the primary goals of treatment for all of the catatonic spectrum disorders are to prevent complications. So some of the complications that are common are aspiration pneumonia due to immobility and just decreased tone. Venous thromboembolism, so like DVTs or PEs are common. So it's recommended for catatonic patients to either start them on heparin or Lovenox for prophylaxis. Constipation with impaction, urinary retention, dehydration, and malnutrition. There is a paper that looked at 4 common complications of catatonia, and they made recommendations for treatment. And they actually said to start initiating tube feeds pretty early, a lot earlier than I would have thought. So they said more than 5 days of inadequate PO intake, they would recommend initiating tube feeds. Obviously monitoring for aspiration and refeeding syndrome. Muscle contracture, so somebody that has retarded catatonia for an extended period of time, they recommended passive and active range of motion exercises and stretching 30 minutes a day. Pressure ulcers in somebody that's spending a lot of time in bed, so a lot of nursing care, repositioning using supportive surfaces. So benzodiazepines are the mainstay of treatment. They are believed to correct the deficient GABAergic function in the orbitofrontal cortex. Lorazepam or Ativan is most frequently utilized. The other benzodiazepines are utilized also as barbiturates, but not as commonly. There's actually not a consensus on a dosing schedule or how high of a dose you should use. Fortunately, at doses that are used to treat catatonia, these are not associated with respiratory depression. So sedation will occur much earlier than respiratory depression will. So the recommendation currently is to start 1 to 2 milligrams of IV Ativan every 4 to 12 hours and increase over several days based on the patient response. IV administration is initially preferred because it ensures rapid and complete absorption. If a patient is already on Ativan at home, it's recommended to increase by 1 milligram 3 times a day, and then to keep increasing by 3 milligrams every 1 to 2 days until you have an adequate response of symptoms. So the doses that I saw most commonly were between 6 to 21 milligrams, and I saw some where patients may occasionally need up to 30 milligrams. The length of treatment is not established, and there's a lot of debate on how long you should continue benzodiazepine therapy. So a number of authors, so basically when you start treating catatonia, you should see a remission of symptoms somewhere between 4 to 10 days in a common case. So then you start treating the underlying illness. So most of the authors recommend treating the catatonia until the underlying illness is actually treated. I saw some sources recommending maintenance treatment with benzodiazepines for 3 to 6 months after the complete resolution of symptoms, so a really long time. So one of the questions I've always had is, what is an adequate trial of Ativan? How do we know when a patient has failed Ativan and we have to go to something else? So Rosebush and Mazurk looked at 180 episodes of catatonia over a 20-year period, And they said that 1 to 2 milligrams of sublingual or IM Ativan repeated in 3 hours and then 2 more times in 3-hour periods, so essentially 6 milligrams over a 9-hour period, is an adequate trial in a patient with retarded catatonia of less than 3 weeks duration. So if they have no response to 6 milligrams of Ativan in a 9-hour period, they have failed Ativan. A patient that has catatonia associated with schizophrenia or a longer duration of time, so more than 3 weeks, that is not an adequate trial, as the symptoms may take longer to resolve. What are some predictors of response to treatment? So previous episodes with recovery. So patients had previous catatonic episodes and they've recovered. Catatonia associated with mania or depression. And going in line with that, catatonia associated with hyperactivity, rapid and pressured speech, and lability of mood. If the catatonia is rapid in onset, so they were well a few days ago and now they're catatonic, that's something that is likely to respond well to treatment. And then good social functioning prior to the episode. By disorder, our affective disorders are a lot more likely to respond to treatment with Ativan, so bipolar depression, bipolar disorder, unipolar depression. It's only 59% of the patients with schizophrenia that are likely to respond to treatment with Ativan, so that's not very high. ECT is the other course of treatment. So there's very few studies which recommend the electrode placement or assessment of seizure threshold, how frequently do you do it. Most of the cases that I looked at used bitemporal ACT. There's no consensus on whether you continue or discontinue benzodiazepine treatment during ECT. You do have to be careful using ECT in a patient that is hypokinetic because ECT by itself will cause a transient rise in serum potassium, and a hypokinetic patient due to muscle breakdown might already have a higher serum potassium, so they would be at increased risk for a life-threatening arrhythmia. I also saw some cases where they use repetitive TMS, but it's just a few case reports and might be more applicable to an outpatient setting. So the response rates to treatment, Hawkins et al. Looked at 178 psychiatric patients, and as I said, Ativan's the most commonly used treatment. And it actually resolved 70% of reported cases. ECT alone without Ativan resolved 85% of cases, so pretty effective treatment. Antipsychotics alone, which I'll talk about antipsychotics here in just a little bit, only resolved 7.5% of cases, so not very efficacious treatment. In malignant catatonia, ECT was the most efficacious, resolving 89% of cases. In antipsychotics, there's only 2 cases where they used antipsychotics in somebody with malignant catatonia, and that showed a 0% response rate. So what are some of the other medications that we can use to treat catatonia? And these are based on case reports, so there's not a lot of data. So it's increasingly becoming more recognized that Ambien can be used as a treatment for catatonia. So it's a GABA-A agonist. It has a really quick onset of action, but it also has a short duration of action. It's been reported to be effective in one case report where Ativan was not, so it might be an option if your patient's not responding to Ativan. And then NMDA antagonists such as amantadine or memantine have been used to treat catatonia. There was a study that looked at 25 cases where the original treatment of catatonia was combined with either amantadine or memantine, and all cases where this was done showed a positive response in 1 to 7 days. You do have to be careful with amantadine because it is anticholinergic and can also increase dopaminergic tone, so use that with caution. And then if you're using an NMDA antagonist, just recognize that the effects are slower than with benzodiazepines, so you might require a longer trial. Anti-epileptics such as Topamax and Depakote have been used some, but there's not a lot of consistent data to show efficacy for these. I do want to say a brief word about atypical antipsychotics. There are case reports of successful treatment with olanzapine, risperidone, ziprasidone, aripiprazole, clozapine. And these have far outnumbered the cases of antipsychotics precipitating NMS. The word of caution here is that most of these were done in patients with a diagnosis of schizophrenia and not a mood disorder. So the advice or the recommendation is to use antipsychotics with extreme caution. It is not recommended in catatonia due to a medical condition at all. It is contraindicated in malignant catatonia, and it must be used with extreme caution in patients that are antipsychotic naive. The last three things that I said, when antipsychotics are used, it is much more likely to precipitate an episode of NMS. So let's look at the subtypes of catatonia specifically and how they're treated. So retarded catatonia, this was the original catatonia that was described. It's most common. It's usually benign and has a favorable prognosis. So the recommended treatment is to obviously pursue workup for the underlying cause, nursing care as appropriate. It is recommended to maintain normal conversation with your patients, even despite their lack of response to you. It is recommended to discontinue treatments with antipsychotic medications to avoid precipitation of neurotoxic reactions. And the treatment, as we discussed, would be with either benzodiazepines or barbiturates, and then to begin evaluation for ECT relatively early on, just in case the patient does not respond. Excited catatonia is also known as delirious mania or the Aneroid state. It's described as excessive purposeless motor activity, restlessness, impulsivity, frenzy, and combativeness. It is characterized by stereotypies, grimacing, posturing, echolalia, echopraxia. Negativism and automatic obedience are almost always present. The patient will have poor sleep, unable to recall recent experiences or names of objects or numbers, and will be disoriented. A lot of times they will confabulate. This does tend to develop rapidly. Patient may or may not have flight of ideas, rambling speech, may alternate with mutism. And the extent of their excessive motor activity can lead to self-injury and harm to others. So I would argue that our patient actually presented and evolved into a case of excited catatonia. So treatment for excited catatonia, just as with other forms, rule out any underlying etiology. It's recommended to use high-dose benzodiazepines, so 1 to 2 milligrams of Ativan or 5 milligrams of Valium every 20 to 30 minutes, up to 10 milligrams within a few hours to get the agitation under control. And as I said earlier, sleep will occur much before respiratory depression. There is literature supporting the use of ammobarbital to treat excited catatonia. The excitement and the agitation might be so great that the patient might actually require general anesthesia. So in that case, they would need to be transferred to the ICU. Use of high-potency antipsychotics such as Haldol increase risk for development of malignant catatonia or neuroleptic malignant syndrome. This is much more likely to occur in a dehydrated patient or a patient that's receiving high doses of lithium. So in the literature, combinations of lithium and high-potency antipsychotics are a risk factor for malignant catatonia and NMS. Also, febrile manic patients and those who have had catatonia in the past that present with excited catatonia are a lot more likely to develop malignant catatonia or NMS. Delirious mania or excited catatonia is life-threatening. If benzodiazepines are not effective, it's recommended to start ECT once or twice daily until the symptoms begin to improve. Moving on to malignant catatonia. So this has actually been described since 1849. It's known as malignant pernicious or lethal catatonia or acute fulminant psychosis. It is acute in onset and can be systemically devastating, and it will be rapidly progressive. It's associated with fever, which is much less likely to occur in an older patient, as well as autonomic instability, delirium, and rigidity. This can occur in a patient with retarded catatonia or excited catatonia. Speech will be disorganized and thoughts will be delusional. The patient can refuse food and liquids. A lot of times it can present looking like something that is an infectious disease or an infectious encephalopathy. So patients will receive very thorough medical workups like our patient did. Lab abnormalities for malignant catatonia are leukocytosis, most of the time with the left ship, an elevated CK, and then a low serum iron, which is something that's common but not necessarily specific. And I will talk about low serum iron on the next slide, I believe. And then the death rate for malignant catatonia is currently around 20%. It used to be much higher, but now that we're better at recognizing it and treating it, it's down to 20%. ECT is the treatment of choice for malignant catatonia, and it's noted that mortality of progressive malignant catatonia is increased if ECT is not initiated within 5 days of symptom onset. So serum iron is something that pops up in just about every paper that I read. So it was first reported in 1991, where Rosebush and Mazurek noted that 96% of cases with NMS had a low serum iron. In 1997, Lee conducted a study where 50 patients with catatonia were prospectively identified in 2 psychiatric ICUs during a 3-year period. They noted that in 39 of those patients, the serum iron was measured in 39 of those patients. 17 patients, or 44%, had a low serum iron. The low serum iron levels were associated with malignant catatonia, excited catatonia, and also a poor response to benzodiazepine treatment. 7 patients in that 50 patient group had malignant catatonia, and all of them had low serum iron. Neuroleptics were used in 5 of those patients, and all 5 developed NMS. There was not a conversion to NMS in patients with normal iron levels or non-malignant catatonia with low serum iron. So the conclusion is that malignant catatonia associated with low serum iron is at high risk for evolving into NMS. The interesting thing is that iron levels will return to normal without treatment, so without iron supplementation, after the resolution of malignant catatonia and NMS. So it's believed to be an indicator of an acute phase reaction, and is a good tool for us to use to know if our patient could progress to NMS. So obviously this leads me into a natural discussion of NMS, so that is what I will wrap up with. So neuroleptic malignant syndrome can be both a progression from catatonia, considered a variant of catatonia, or a complication of catatonia. There's a lot of argument in the literature whether or not it's on the same spectrum, or whether or not it's really the same thing. So basically it's just something you have to be aware of, and it's highly associated with catatonia. So the incidence of NMS is 0.2 to 3% among patients taking neuroleptic drugs. It's noted that approximately 16% of patients will develop NMS, of that small percentage that will, within a 24-hour period of initiation of antipsychotic. If they're going to develop NMS, 66% of them will do it within the first week, and almost all cases will evolve within the first month of treatment. 3.6% of patients with catatonia develop NMS. The mortality of NMS was pretty high before the 1960s, so 76%. It's much lower now at 20%. And the mortality usually results from dysautonomic manifestations and from systemic complications. So what are the clinical manifestations of NMS? So there's a tetrad of symptoms which will evolve over a 1 to 3 day period and will be present in 97% to 100% of patients. So the initial symptom in 82% of patients will be mental status changes. These are described as agitated delirium with confusion rather than psychosis, catatonic signs such as posturing, waxy flexibility, and catalepsy, and mutism. There's frequently an evolution to encephalopathy with stupor and coma. The mental status changes are followed by muscular rigidity. So this is the lead pipe rigidity that we're all familiar with. The rigidity is often generalized and extreme, but doesn't have to be. Um, there's frequently a superimposed tremor, which may lead to cogwheeling. A tremor is present in about 45 to 92% of patients. Less commonly seen are other types of dystonia um, or chorea or dyskinesias. It is common with muscular rigidity to develop sialorrhea, dysarthria, and dysphagia. So this is what's going to lead to the aspiration pneumonia. Hyperthermia is a defining symptom. So most patients, 87%, will have a temp of greater than 38 degrees Celsius. Autonomic instability is our final symptom. So 88% of patients will have tachycardia. 61 to 77% of patients will have labile or high blood pressure. Tachypnea is common at 73%. Dysrhythmias, and then profuse diaphoresis is another marked feature of NMS. So in analysis of 340 cases, 70% followed this typical course. First mental status changes, then rigidity, then hyperthermia, and then autonomic dysfunction. The fever can take up to 24 hours to develop, so it may not present soon. It is noted that there is a substantial variability in the presentation, and so it's really reasonable to suspect and consider a diagnosis of NMS with just the presence of 2 to 4 symptoms in the setting of treatment with neuroleptics. Some early signs of NMS, and these also apply to malignant catatonia. As I'll talk later, the clinical picture between NMS and malignant catatonia is virtually indistinguishable in 20% of cases or more. A lot of the slides will have kind of NMS with malignant catatonia in parentheses because it does apply to both. So rapidly developing EPS, such as rigidity, tremor, dyskinesia, with the initiation of low to modest doses of antipsychotics, mania with fever, any catatonic features that develop within 24 hours of initial antipsychotic administration, autonomic instability developing within 24 hours of initial antipsychotic administration, and then sialorrhea in that same time period. Some risk factors for NMS, as I said, catatonic features, past or present. Dehydration, it's unclear if dehydration is a warning sign, a risk factor, or an early complication, but it is present in 92% of patients with NMS. Another risk factor is substantial agitation or excitement, any kind of EPS, tardive, previous episodes of NMS, electrolyte imbalances, exposures to high temperatures, patients that are receiving high-potency antipsychotics or 2 or more antipsychotic drugs. The development of NMS is not dose-dependent, but an increase in dose and high-dose agents put you at an increased risk. And then changing from one agent to another also increases the risk. Receiving high-potency antipsychotics with antidepressants or mood stabilizers, receiving IMs, and then recent alcohol abuse with liver dysfunction also increases your risk for NMS. There's a whole list of drugs associated with NMS that I'm not going to read to you. Obviously, antipsychotic drugs, including clozapine. I do want to point out that metoclopramide and other GI drugs can precipitate NMS. Abrupt withdrawal of drugs used to treat Parkinson's, or as well as antipsychotics, can precipitate NMS, as well as substances of abuse like cocaine, PCP, or benzodiazepine or alcohol withdrawal. So lab abnormalities that are seen in NMS, so the one we always look for is an elevated CK. So the more severe the rigidity, the higher the CK. The elevations are generally greater than 1,000, but can be as high as 100,000. The DSM actually defines it as an elevation in CK 3 times the upper limit of normal. So whatever the upper limit of normal per the lab is. A normal CK can be seen early if the rigidity has not developed yet. The degree of elevation correlates with disease severity and prognosis and will typically normalize after an episode of NMS. Leukocytosis with a left shift is very common. There's usually a mild elevation in lactate dehydrogenase, ALK-Phos, AST, and/or ALT. There are electrolyte abnormalities, so low calcium and low magnesium, high potassium from muscle breakdown, low and high sodium, and then metabolic acidosis. There can be presence of protein and myoglobin in the urine, thrombocytosis, and then again, the low serum iron. It is sensitive 92 to 100% of the time, but not specific, and we've discussed that earlier. So differentiating NMS from malignant catatonia, there's a lot of literature kind of devoted to this. As I said, in 20% of cases, it is indistinguishable. They can both lead to muscle injury, aspiration, metabolic disturbances due to hyperthermia, and then altered mental status. NMS, obviously, you'll have an exposure to neuroleptic agents or atypical antipsychotics, and then acute onset of rigidity, autonomic dysfunction, fever, and stupor. For malignant catatonia, there is usually a prodrome that is psychiatric in nature, so psychosis, agitation, stupor, mutism, anxiety, and then malignant catatonia is often manifested by bizarre behaviors, mutism, posturing, catalepsy, and psychiatric disturbance. There's a study that looked at 386 articles that contained 490 case reports. 390 of those were diagnosed with NMS and 100 with catatonia. So the clinically significant symptoms in NMS, so the first one was fever, rigor, followed by rigor, then lab evidence of muscle injury in only 70.5% of cases, and then tachycardia, and then clinically significant symptoms in catatonia were mutism, rigor, stupor, and agitation. So they put together this chart with odds ratios. So basically, moving from the top, if patients present with diaphoresis, rigor, and fever, it's more likely to suspect a diagnosis of neuroleptic malignant syndrome versus stereotypy, stupor, waxy flexibility, and such moves to suspicion of catatonia. So treatment of NMS, the very first thing to do, obviously, is to discontinue the offending agent. Once diagnosed and the antipsychotic has been discontinued, NMS is actually self-limiting and should resolve in 7 to 10 days. 63% recover within a 1-week period, and then nearly all within a 30-day period. You obviously have to provide supportive medical therapy, aggressive volume resuscitation to protect the kidneys, serial monitoring and correction of electrolyte abnormalities, physical cooling. It is noted that the peak and duration of temperature elevation are predictive of morbidity and mortality. So monitor for complications that I discussed earlier. There's no general consensus on specific pharmacologic treatment for uncomplicated NMS. And then when do we restart antipsychotics? After a case of NMS, generally at least 2 weeks after the full recovery of symptoms. There is a 30% chance of developing NMS after you've already had an episode of NMS, so it's recommended to start antipsychotics at a very low dose and to escalate slowly. So the treatment algorithm for NMS, we're going to move straight down to stage 3 because the first 2 are really more EPS-related things. So mild early NMS, which is marked by mild rigidity, catatonia, or confusion, and then temperatures that are below 38 degrees Celsius and a heart rate below 100 beats per minute. So again, like I said, discontinue the antipsychotics and then carefully monitor for any progression of symptoms. And then it is recommended to start treatment with Ativan 1 to 2 milligrams IM or IV every 4 to 6 hours. Moderate NMS, so something which would be marked by moderate rigidity, catatonia, or confusion, temperatures between 38 and 40 degrees Celsius, and a heart rate between 100 and 120 beats per minute. So here, obviously, managing fluids, initiating cooling measures, correcting risk factors, and providing intensive care. It's recommended to start treatment with Ativan, bromocriptine, or amantadine, and then to consider ECT. if those are ineffective. And then severe NMS, so severe rigidity, catatonia, or coma, temperatures above 40 degrees Celsius, and a heart rate greater than 120 beats per minute. The same supportive measures, but at this point, the first line intervention is believed to be dantrolene, followed by bromocriptine or amantadine, and then consider ECT. So just a brief word about amantadine, bromocriptine, and dantrolene. So those are the dosing ranges. Amantadine is a presynaptic dopamine agonist. Bromocriptine is a postsynaptic dopamine receptor agonist. At high doses, it can exacerbate psychosis, lower blood pressure, cause vomiting, increasing the risk for aspiration. And then dantrolene is a muscle relaxant, and it is hepatotoxic, so it can't be used in patients that have underlying liver dysfunction. So going back to our case, what do I think actually happened? So as I said, our patient didn't meet criteria for diagnosis under DSM, but he did using the Bush-Francis Catatonia rating scale. So if you take anything away from this talk, I would recommend that you use the Bush-Francis Catatonia rating scale. It's very readily available on the internet, and to evaluate cases of suspected catatonia. So did our patient have malignant catatonia, NMS, or both? So I would argue that he actually presented with excited catatonia, which probably progressed to malignant catatonia and then converted to NMS after he received IM Haldol. I would argue that he likely had a mild episode of NMS during the course of an initial hospitalization after he received Seroquel. As I said, his serum iron was unfortunately not checked. That's the one lab I would have really liked to have had on him. And then all of his other workup was negative. So key takeaway points. Catatonia should be viewed as a syndrome of related disorders with heterogeneous presentations that makes diagnosis difficult at times. While retarded catatonia is most common, remember that excited catatonia can be more severe and is really under-recognized. Utilization of a rating scale, such as the Bush-Francis Catatonia rating scale, can be helpful. If a diagnosis of catatonia is suspected, antipsychotics should be used with extreme caution, especially in antipsychotic naive patients, and antipsychotic treatment is contraindicated in malignant catatonia. I would recommend checking a serum iron in all patients with catatonia or that you suspect might have catatonia. And then treatment of excited catatonia, malignant catatonia, and NMS are all time sensitive and should be initiated quickly to reduce the risk of mortality. So stopping all antipsychotic medications and not using them again until symptoms resolve. Ativan or other benzodiazepines for agitation, supportive care, monitoring for complications, and then initiating ECT within 3 to 5 days if benzodiazepines are not successful in treating symptoms. So that concludes my presentation. I'd like to thank everybody that I've worked with. So a very special thank you goes out to Dr. Spurgeon and Dr. Hedinger, who gave me the opportunity to train here. I'd like to thank Dr. Caudill, Dr. Fitzgerald, and Dr. Casey. My advisors, Dr. Wright, Dr. Tamus, Dr. O'Connor, and Dr. Tasman. Other faculty members, I'd like to thank Dr. Campbell, who has been available 24/7 and supporting me through work and other things. I'd like to thank Dr. Khalil for everything he's taught me this year. Dr. O'Malley, who couldn't be here today, Dr. Terrell, Dr. Ruth, and Dr. Boven. I'd like to thank my classmates who have been awesome to train with, and I'd like to thank my family whose support has allowed me to do this. So these are my sources, and I'll take any questions. Yeah.
When you think about the catatonia system, I think the first criteria, most famous criteria that comes to mind is catatonia, posture, mutism, vital flexibility. But I'm glad 12 criteria in the sample, I think 3 out of 12 is enough to do the diagnosis. patient was diagnosed with dementia like 6 months before we started treatment, and basically, I mean, he was transferred to us because we also diagnosed with bipolar. He transferred us because of possible seizures, and we identification. Basically, I mean, he was in the unit for 2 months. We just, waiting for a placement. And then, I mean, he realized that actually he was meeting criteria for Catonia. There's like 4 out of 12, but none of them in the like clinic, posturing, flexibility, like weren't among them. We did ECG, and after like 30 ECG, it was normal. Like
Right.
he was like almost not meeting criteria for nursing home. I was wondering how many patients diagnosed with dementia out of the, who has actually, who actually has catatonia.
So misdiagnosis is common. I didn't see any specific like symptom or any specific statistics on patients diagnosed with dementia that are actually catatonic, but and I think I talked about it at the beginning. So the most common symptoms of catatonia are actually immobility and mutism. So I suspect that that is what your patient had. And then withdrawal or refusal to eat, staring. So that, rounds out 90% of patients. And, patients with dementia can have all of those symptoms. So I would suspect that, misdiagnosis is relatively common. Dr. Casey.
That was a wonderful talk. Wonderful comprehensive talk.
Thank you.
It reminds me of a lot of patients that we've seen her over the years. And a lot of there's catatonia, especially catatonia, there's lots of mistakes. We don't really understand catatonia all very well.
Right.
But a couple of interesting comments. There's a condition that you hear about occasionally called Brikker syndrome. That is, the person who is withdrawn for very long periods of time, sometimes regarded as being comatose, who then receives benzodiazepines exclusively for medical procedures, and then they wake up. Sometimes for a long period of time, sometimes for a short period of time, sometimes there's a chain response to benzodiazepines, sometimes not, so they go back to the way they were before. And clearly, these are people that have some version of catatonia. We don't know the symptoms very well. So that's the first thing. I also wanted to brag a little bit about UL. We had a series of patients with
selected that specifically because Ativan's the most commonly used. And the patient in case, I initially had 30 slides on his case presentation that I was instructed to cut because it would have taken me too long to talk about that. But was actually getting PRN Ativan on top of the Valium. So, yeah, I mean, he got a couple. It wasn't like consistent, but he was getting PRN Ativan on top of what he was already getting. No, yeah, no, no. I mean, I think that like looking back at this case, and I looked at it pretty thoroughly. I mean, I think the patient needed ECT relatively early on. So, that's all.